Hello, I'm Steve Kleiboeker, Chief Scientific Officer at Eurofins ViraCore. Welcome to our webinar on innovative clinical diagnostics. It's my pleasure to introduce today's speaker, Dr. Gaurav Gupta. Dr. Gupta is a professor of medicine and surgery, division chief of nephrology, and the medical director of kidney and pancreas transplantation at Virginia Commonwealth University. As a nephrologist, he specializes in transplant rejection and infectious complications of kidney recipients. He's published a large number of important manuscripts in this area. Today, Dr. Gupta's presentation will focus on non-invasive biomarkers in transplantation recipients with an emphasis on Teno and assessment of the immunosuppressive burden in these patients. If you have any questions for Dr. Gupta during the presentation, please put them in the chat and we will have Q&A at the end. Dr. Gupta, please join us with your presentation. Thank you.
Thank you, and good day to everybody who's listening. So as Steve mentioned, the focus today is on a specific kind of virus called Teno. And the context that I'll be talking about today is mostly for patients with kidney transplants, although there is a significant amount of literature on this virus in the context of other solid organ transplants, as well as for bone marrow transplants. These are my financial disclosures. So I'll start with some background today, which I'm sure most of the audience may already be familiar with. But the question to ask is, why do we need biomarkers to detect early injury? So the reason is that subclinical injury can continue for a long time before it's detected by routine markers like serum creatinine for the kidney transplant, and change in heart function, ejection fraction for heart transplants. So the goal here is to catch patients when they are in this dark colored zone in the middle before clinical dysfunction becomes apparent with the use of biomarker testing, which is novel. So this can be seen nicely in this graph where creatinine measurements barely change between GFRs that range all the way from up to 180 down to 60. And therefore, serum creatinine is a poor biomarker for early dysfunction detection. And that's the reason why we would like to develop new biomarkers which are more precise for early dysfunction. So there's been a tremendous interest in developing a variety of biomarkers in blood and urine over the last 20 years. And this is a list of those biomarkers that have been reported on. And what you will notice about these biomarkers is that the majority, if not all of them, are focused on the early detection of transplant rejection. And the goal today for me is to convince you, possibly, that shouldn't be our entire goal, and we should be thinking about other things beyond rejection for our patients. So the question to ask is acute rejection the real enemy, or possibly is acute rejection the only enemy for our patients? So if you look at the top part of this graphic, clearly acute rejection rates for kidney transplants were high up till 2000 in the range of 20 to 50%. But then beyond that, you'll see that pretty much rejection rates have flattened out over the next 10 years from 2000 to 2010. And that trend continues even till this most recent publication, which is the bottom half of this graphic, where rejection rates have pretty much stayed stagnant at around 10% or so up till 2017. And you can look at this data in many different ways, be it from registries, from claims-based data, or a combination of both. So essentially, rejection rates within the first year of transplant are around 10%, and those haven't changed. So to summarize what I'm trying to say, only 1 in 10 of our patients tend to have rejection, mostly T-cell-mediated rejection, in many cases associated with non-adherence. But what I would like to argue is that may not be true for other problems that we see, which is infections and other problems. So how have we been doing for the last 30 or 40 years in terms of transplant outcomes? This is a nice summary that was published a few years ago in the New England Journal of Medicine, which looked at patient and graft survivals over over 5-year eras over a period of 25 some years. And what you notice is that both patient survival in the top and graft survival in the bottom have improved over time. But to give you some numbers, for example, graft survival improved from 42% in 1996 to around 54% in around 2008. And then for patient survival, it improved from 60% to around 66% around the same time period. So although graft survivals improved a fair bit, patient survivals have improved somewhat, but not enough, and they're lagging behind graft survival. So the question is, we need to keep our patients' survival better than where we are right now. So why do our patients die? I think I'm sure many of us have seen this graphic before. Nearly half of our patients die because of cardiovascular disease over time. And the most common reason for that is because they bring a significant cardiovascular disease burden with them to transplant, but then it worsens over time because of metabolic disease, because of associations with immunosuppression, associated adverse events like hyperlipidemia, hypertension, etc. But then if you look at the other half of the mortality, around 20% of our patients die because of cancers, and around 15% die because of infections. So truly speaking, we need to tackle this issue of a high rate of malignancy and infections in our patients by trying to optimize immunosuppression. Now, you could argue this data is only up till 2008. So how have we done since then? And this is the data up till 2014. And what you see in the bottom purple line is that the rate of mortality because of malignancies has basically been a flat line for nearly 20 years. So really, we haven't made any progress in improving mortality from cancers in our patients. And the same is true broadly for infections, with some improvement by 1 or 2%, but not really a significant improvement with regards to infectious-associated mortality. So again, the message here is that we need to do better. And can we do better? So ultimately, as all of us know, pretty much most of transplantation is this yin and yang of too little immunosuppression, which causes rejection, or too much immunosuppression, which causes cancers and infections. Or in Star Wars lingo, can we try to bring balance to the force? And ultimately, what we're looking to do here is to try to develop this idea, this concept of an immunostat, where if we could just dial the right temperature, in theory, we could prevent infections and we could prevent rejection. But that, of course, is the holy grail of what we do. And the point here is, can we develop tests which are not available right now, or can we develop better literature for what is available already to implement them in our clinical protocols? So the first test that was developed to measure the net burden of immunosuppression was the immune cell function assay, or CILEX as it was called at the time. And the concept of this assay is shown in the slide here. The idea is that a sample of whole blood is incubated with phytohemagglutinin, or PHA for short, for close to a day, 15 to 18 hours. And this PHA then stimulates lymphocytes. And the focus of this assay is mostly on CD4 positive T lymphocytes. What happens then is that these activated lymphocytes produce ATP, and the eventual steps of this assay eventually lead to a measurement of the total ATP produced by these CD4 cells, which is then presumed to provide a numerical quantity of the net functional state of immunosuppression based upon CD4 T cell activity. So, the one thing which may stand out when you look at the slide is the complexity of this assay. It's fairly cumbersome. Fresh cells are required to do this, and the sample has to be shipped overnight for it to be done. And that has been one of the limitations in terms of implementing this assay in routine clinical protocols. Beyond that, the data has been less than exciting. So these studies, which are highlighted here, were done over a period of around 10 years in the early 2000s. And this is a meta-analysis of those studies. One thing to point out is they are a combination of heart, kidney, and other organs. So it's not just kidney studies here. But eventually what you see is that this meta-analysis included only 9 studies. And when you see in the middle is infection, and this forest plot shows the pooled estimates for the immune cell function assay to identify infection was not ideal. It was fairly poor, with a sensitivity of 58% and a specificity of 69%. When you look at the rejection pooled estimates, they're on the right. And what you see here is a sensitivity of 43% and a specificity of 75%. So all in all, this assay did not perform as well as it would like, and therefore over the years it has fallen out of favor in terms of widespread use among providers of kidney transplant patients. So in that context, I'm going to now shift gears and talk about a test that may potentially help us measure the net state of immunosuppression. And the test we're going to be talking about for the rest of this presentation is a Teno virus, or TTV for short. So TTV is a non-enveloped human DNA virus, which was isolated by Nishizawa in 1997. And since then, it has been classified as the alpha torque virus genus within the anilovirus family. This virus is characterized by an extremely high prevalence of 90% or above in the human population. And I'll show some data about that in the next couple slides. And it has a fairly uniform distribution worldwide. TTV viral loads seem to increase under conditions of compromised immune systems, and replication of TTV seems to be inversely correlated with the number and function of T lymphocytes. And once again, I'll share data about that in the next half of this talk. So an important point to note about this virus, as I mentioned before, is it's fairly ubiquitous in our environment. It's prevalent in air, on most surfaces, and fairly resistant to damage. What you can see in the study from a hospital environment is that TTV was isolated from a majority of locations, both in the outpatient and inpatient settings, both in the air as well as surfaces. So essentially, we are being exposed to TTV virus pretty much all day in most of our day-to-day settings. And that's why you can see the prevalence of TTV in children. And this is now isolated from blood, from stools, from urines, a variety of human biospecimens. And what you can see is that after birth, by the age of around 4, a majority of human population now becomes positive for TTV by PCR-based assays. Beyond this, what you see also on the right is that there's a significant amount of genetic diversity within this virus, with more than 50 genotypes discovered so far, and within 5 phylogenetic groups. So there is a lot of diversity, and that can make amplification of the virus challenging. But from what I was able to tell based upon my reading on this particular topic, was that the non-coding control region of the virus seems to be fairly conserved across the different strains. So this is the first landmark study which was published on TTV in 2013 by Development with a number of NIH-based authors. And what they looked at was nearly 100 thoracic transplants, heart and or lung transplant patients. And they looked at their whole cell-free DNA in the blood on a longitudinal basis over multiple months before and after transplant. So they used sequencing of cell-free DNA in the plasma to investigate the drug and the virome interactions in these recipients. They looked at nearly 700 samples from nearly 100 patients, and they observed a marked virome dynamics at the onset of immunosuppressive therapy and found that the total viral load of all of the viral burden, the virome in the patient's plasma, increased with immunosuppression, whereas the bacterial component of the microbiome remained unchanged. And the most interesting thing that I want to highlight is in the blue block here, where the bulk of the virome in these patients is formed by Teno, as can be seen in the brown shades of different kinds, from all the way from TTV1 to TTV8, which you can see. So narrowing it down to after transplant over multiple days, which you can see at the top, 0 to 300 and then up to 900 days. What you see is that the spectrum of the virome changes over time. And in the orange color, what you see is that the proportion of aneloviruses in the virome expands with increasing amounts of immunosuppression. So the other viruses remain the same, but the aneloviruses seen in orange keep expanding over time with increasing immunosuppression. You can further see the temporal dynamics of this distribution over time post-transplant here, where once again, early on, when the intensity of the immunosuppression is high, aneloviruses form the bulk of the virome, but as intensity of immunosuppression goes down, the virome alters with less anelovirus. And what you see in the bottom is bacteria do not change in any significant way. So this was even more striking for those who had rejection. So what you see on the left in the dark red line is that for the patients who had rejection, Teno TTV did not go up as much compared to those who did not have rejection. So in the blue line are the non-rejectors, where you see the somewhat of a bell-shaped curve with left skew, as opposed to the red line where the rejectors, the trend upwards in TTV was much lower. So the summary of this slide is that patients with rejection who had lower levels of TTV and therefore potentially were less immunosuppressed, and that's why they had more rejection compared to those who had more immunosuppression and therefore their TTV was higher. You also see this on the right in terms of a gradation between those with mild versus severe rejection, where TTV was highest in non-rejectors, in the middle for mild, and then the lowest for those with severe rejection. The same trends have been seen in bone marrow transplants, where TTV goes up early after transplant. But as the T cells repopulate, as the graft is engrafted into the human, TTV viral loads go down. But there is a difference between those with GVHD, graft versus host disease, versus those without, where GVHD patients have a more of a spike in TTV than non-GVHD patients. Similar data has been shown for liver transplants. My goal is not to talk about other organs here, but I wanted to give you a flavor that the viral trends of TTV are agnostic to organ transplant type. They seem to fall nicely in terms of immunosuppression burden versus less or more. So one of the questions that comes up is, where does TTV come from? And this is a bone marrow transplant population of children. And what you see in the first cartoon is that TTV is shed in stools, and it basically mirrors what you see in plasma. Pretty much the lines march out together. And the theory is that maybe it comes from gut leukocytes. The second set of cartoons in the middle deals with the question as to where it is coming from. And what you see here is that almost all of the TTV in white blood cells was isolated from neutrophils, as opposed to lymphocytes, natural killer cells, or monocytes. On the right, what you notice is that the amount of TTV detected from whole blood is uniformly higher than that seen in plasma, which confirms that there are cells like neutrophils where the virus is replicating. Having said that, it's not just neutrophils. Platelets are considered as the second most likely source of TTV. And finally, in the bottom table, what you see is that compared to a control cohort of non-bone marrow transplant patients, both the plasma and the neutrophils of stem cell transplant patients is more likely to be positive indicating what we have discussed before, which is the association of TTV with immunosuppression. So overall, the message from this paper remains that plasma TTV can be used as a biomarker, and this is what makes it a very handy and cheap test for these kinds of patients. So with that, I move on to the first large study in kidney transplantation patients. And these are investigators from Vienna. So what I will point out that the majority of publications come from Austria. And one limitation of a majority of these publications is the kind of immunosuppression used, which is fairly homogeneous, which is that all patients received basiliximab induction in the study, as opposed to thymoglobulin or other T-cell depleting agents that are used in the US. And then almost all of these patients were Caucasian. So with that context, this was a study of nearly 280 patients. And you will notice this was a small population of patients with rejection, only 11, and 127 with infection. So if you remember, I mentioned earlier on, infection is far more common in our patients than rejection. And therefore, maybe rejection is not our primary enemy. So all TTV measurements are shown in this slide here. They had nearly 3,000 measurements in the total cohort. And what you see is a similar trend of TTV as I showed you in the thoracic transplant paper, where there's an uptick of TTV from around 10,000 copies median at transplant to around nearly 1 billion copies at around 3 months post-transplant. And then it plateaus subsequently when we look at the entire cohort over time. It goes down and then it plateaus at around 1 million copies or so by 12 months post-transplant. So upon creation of ROC curves to predict rejection or infection, now keep in mind the events for rejection were only below 20, while the infection events were more than 120. So what the authors found was on the left that each log increase in TTV load decreased the odds of rejection by 22%. Essentially meaning more TTV, less rejection. And the median for those with rejection was around 1 million copies per ml. And on the right, what you see is that each log increase was associated with an infection rate rise by 11%, with a median of around 100 million copies per ml. So what they suggested was, based on this data, was that maybe 10 million copies per ml may be the optimal immunosuppression for these patients by 3 months post-transplant. Now, one point to note was that these samples were drawn around 14 days before clinical rejection and around a month before clinical infection diagnosis. So there seems to be a suggestion here that there was a lead time for viral detection before clinical events were diagnosed. So eventually, over the last 4 or 5 years, there have been multiple other studies that have been done on this topic, and this meta-analysis published last year summarizes these publications. I want to point out a few things on the slide. The font is too small probably for you to read it, but the basic points which I want to point out is what I said before. One is that almost all of these studies have been done outside the US. And you will notice Austria comes up frequently. And the other one thing I want to point out is the assays used in the studies has been variable. So the TTV PCR has been done by multiple different kinds of assays, which does impact the interpretation of viral loads when we go from one paper to another. So this is the summary of this meta-analysis, which I showed you in the last slide. What you see here is that in this forest plot at the top for rejection is that lower TTV loads were associated with a sensitivity of 61% and a specificity of 81% for rejection. And in the bottom half for infections, a higher TTV viral load was associated with a sensitivity of 72% and a specificity of 57% for infection. So if you try to put these numbers together in the context of what we already know from other biomarkers, it indicates that TTV is a modest indicator for risk stratification, by no means an excellent predictor, but a modest one. So the other issue to highlight is trying to come up with standardized thresholds for populations rather than individuals. So in this summary from the same paper, from 5 papers which looked at this issue of infection, what you see is that the thresholds for infection prediction are very wide-ranging, from 3.5 log 10 to all the way to 9.8 log 10, with a very wide span of sensitivity and specificity. So the issue here, of course, is that the assays are different, and because of that, the results are different. So what kind of assays are available right now for measuring TTV? So what you see on the left is the TTV-R gene assay, which is now available commercially over the off the shelf in Europe. And this is being used by a number of European academic institutions, primarily in the context of a large clinical trial, which I'll talk about at the end of this presentation. And what you see on the right is the commercial TTV assay by Eurofins ViraCore, which is available to US populations at this time. How do the two correlate to each other? Apparently the assay is similar, but once again, that needs to be borne out. So one way is to do the viral assay on its own using real-time PCR, as I showed you in the last slide. But then an interesting concept that was shown recently is in this paper using metagenomics. So in this study, nearly 2,000 samples from around 270 patients that were enrolled in the CTOT-8 trial are included. A whole cell-free DNA has been amplified, and it was found that 3% of the sequences were non-human. And using computational analysis, they were then able to assign species-level taxonomic assignment to a variety of these viruses. And what you see in the table below is the detection thresholds using metagenomic NGS, next generation sequencing, versus real-time PCR or qPCR, where detection thresholds are certainly higher than for real-time PCR, but they are detectable. So for example, for TTV, which you see in the bottom half, the last row of this table, mNGS was able to pick up TTV, but only at a threshold of 10,000 copies per ml compared to the qPCR cutoff. So for lower TTV viral loads, it may not be as sensitive, but it is sensitive for higher cutoffs, which is probably adequate in the context of what I've shown you before in terms of what we've seen with European transplant studies. What was interesting in this paper was also the fact that pathogenic viruses using this technique like BK, CMV, EBV were picked up several days to months prior to clinical diagnosis of these infections. So this is an interesting concept to take away, I think. So I've been telling you that none of the studies that have been published so far are from the US. So we tried to bridge this divide a couple years ago. We partnered with Natera to do a single center study where we looked at TTV dynamics in our single center US cohort. We are a large urban center in Southeast US, and our population is 2/3 African American. So we looked at 236 samples from nearly 60 transplant patients with kidneys. And this was a curated data set. So we looked at samples, essentially convenience-based sampling for patients where around 30 patients were controls, meaning they did not have any clinical events like infections or rejection or BK in the first year post-transplant. And they had 4 samples, 1 at the time of transplant, and then 3, 6, 9, and 12 months post-transplant. We had around 10 patients with BK. Once again, 1 sample at transplant, 1 sample before BK, 1 sample at BK diagnosis, 1 sample after a few months at 12 months post-transplant. We had 22 antibody-mediated rejection patients and 7 with T-cell-mediated rejection. The goal was to focus primarily on antibody-mediated rejection in our study because of the fact that all of the studies that I described before were done in the context of T-cell-mediated rejection detection only. So a few points stand out in this preliminary analysis, which I want to highlight here, was the overall trends in our analysis essentially mirrored published studies from Europe, which confirms that the geographic distribution of the virus and the impact of immunosuppression is similar to in the US compared to European data. The median TTV at transplant was, in our study, was around 100,000 copies per ml, which is again not too dissimilar to what we saw before. And it rose to around 10 million copies per ml at a median at 3 months post-transplant. And then it trended down. So overall, what you see in this figure in the middle and in figure 2 is these 4 lines. What you see in the blue line is the control population, where you see that the virus goes up by 3 months and then it goes down, like we expected to. We saw similar trends for BK, so we couldn't really differentiate any difference between BK versus controls. But what was distinguishable in our data cohort was for antibody immune rejection, there was certainly a lower peak for patients with AMR compared to those without AMR. Now, the one problem with this whole thing, the 2 problems with this data are, one is that we have a very small population at hand, and 2, samples were not drawn exactly at the appropriate time points, which can muddy the interpretation of this data. The third point, which I want to talk about, is the fact that there was very wide variability in between patients. So what you see, for example, in these dots are there are many, many patients who are at 1,000 copies, and they go up to 100,000, but then they come down to below 100,000. So the message here is that, at least to us, based upon this data, these population-based thresholds of 10 to the power 6, 7, or 8, which the European publications have described, does not seem to hold true. So in our interpretation of this data to us is that what we probably need is individualized thresholds, meaning trends to be noted within the patient as opposed to entire populations. Having said that, we acknowledge the sample size here is too small to make any clear conclusions from. So there's other interesting data that is available now. I'm going to share 2 or 3 more trials with you. What you see on the left here is the impact of tacrolimus adjustment, dose adjustment, and its impact on Teno virus. So what you see in at the top half of this cartoon on the left is that as you lower tacrolimus levels, meaning as you lower the TAC dose, Teno virus goes down overall, which is consistent with the fact that the overall burden of immunosuppression is going down. And what you see in the lower half of this cartoon on the left is as you increase the TAC dose, TTV viral loads go up. And what you're seeing is that this change doesn't happen within 30 days, but it takes up to 60 days for this change to become manifest. So essentially meaning that you can measure TTV changes with even short-term changes in tacrolimus dosing. The second study on the right is about mycophenolate dosing. And what they did in this study was they looked at a retrospective analysis of patients who were in a clinical trial where patients who were getting vaccinated for COVID had temporary cessation of mycophenolate for 5 weeks. The idea in this trial was to try to see whether holding mycophenolate may result in better immunogenicity to the COVID vaccine. So here in this trial, 43 patients had MPA or mycophenolate cessation, and 33 did not have any change in immunosuppression. So the overall message from this paper is that TTV viral load was highest in kidney transplant patients, which is not surprising, followed by hemodialysis, and followed by healthy controls, which is again not surprising. It decreased significantly in patients with transplants who underwent mycophenolate withdrawal, which is again consistent with what we expect, because as you cut back immunosuppression, TTV goes down, and then when you resumed MPA, it went up again. And lastly, this is to me the most interesting part of this paper, is that TTV load was inversely correlated to SARS-CoV-2 antibody levels amongst patients who had withdrawal of MPA and had the vaccine. So essentially meaning that you could use, in theory, this test to understand who may or may not respond to immunomodulation with vaccines. So this study looks at ABO-incompatible transplants. Now, the historical context is that we've known that ABOI patients have more BK virus infections than those who get other types of transplants. So this study tried to explain this phenomenon, and what they did was they looked at patients who received ABO-incompatible transplants, patients who received HLA-incompatible transplants, and controls. So once again, you will notice this is from Vienna. They had 42 ABOI, 100 HLA-I, and the remainder of controls. So at 3 months post-transplant, as well as 6 months post-transplant, ABOI patients have higher TTV loads at 1.5 or 3.1 billion copies per ml. This is higher than those for HLA-I transplants, and HLA-I, of course, is higher than controls. And of course, you see the rates of BK in these populations. So BK rates for ABOI is around 12%, while only 3% for HLA-I. So the message here is that what the authors say is that ABOI patients do have more BK, and the reason is not about anything biologically about ABOI, but rather the overall burden of immunosuppression, which is mirrored by TTV viral loads in these patients. And this is the last trial I'm going to talk about. And what I want to highlight here is this is an international multi-center trial in which around 100 patients with kidney transplants were randomized to either continuation of CNI, calcineurin inhibitor, or conversion to belatacept. And what you see on the left in the first cartoon is the TTV goes down over time post-transplant and stays low in those who continue tacrolimus. But in those converted to belatacept, TTV goes up again and then it stays up, which you can see in the blue dots. So this suggests that in the long-term Bela patients, there is more immunosuppressive exposure than patients maintained on tacrolimus. And for those of us who manage patients on belatacept, that seems familiar because we saw during the COVID pandemic, patients on Bela had poor responses to vaccines and had worse outcomes with COVID compared to those on TAC. So this data suggests that there is something intrinsic about Bela or about the intensity of how we dose belatacept, which results in more immunosuppression than those on tacrolimus. So how is this all translating out into clinical trials? This is the first trial, which is called Vigilance. This is in patients with lung transplants. There are 2 randomized arms here, arm 2, which is conventional tacrolimus dosing, and arm 1, in which the clinicians are allowed to titrate dosing of immunosuppression based upon TTV viral loads along with TAC levels. The study is ongoing. We don't have any published data on this as of now. This is a second trial, which is in kidney transplant. This is called TTV Guide IT. So here they do have specific thresholds which they have defined, although the range is wide. So what you see again in the bottom half is the control group, whereas there's no specific TTV-based guidance. The physician can titrate immunosuppression as needed. And then in the active group, you have TTV above this limit of 6.2 log 10, where you reduce the TAC, and then below the limit of 4.6 log 10, where you go up on the TAC. Now, this is multi-center, multinational in Europe. Once again, we don't have any published data yet on this. So what are the unanswered questions and directions in this area? So the pros of TTV, in my opinion, are that plasma is absolutely the easiest to analyze. As I've shown you that the virus is stable, highly resistant in terms of damage, and plasma probably stays stable for TTV detection for days, if not weeks or months. This assay is much cheaper than most biomarkers available. It can be used off the shelf or sent to a commercial lab. And as opposed to rejection only, it may provide a better gauge for the net state of immunosuppression and can reduce infections and cancers, as I talked to you about earlier today. What are the cons and what next about this? Well, the current data do not support population-based thresholds, in my opinion, based upon standardized TTV viral loads. In my opinion, the ideal way to use the assay would be to assess each individual strain. And that, of course, remains an unmet goal in terms of future studies. As I mentioned, most of the studies are from Europe. We need more data from the US. And lastly, given only moderate sensitivity and specificity, in my view, the ideal approach to use TTV may be in combination with other biomarkers. So with that, I'll end with how we are anticipating using this assay in our population. So this is an abstract we presented at the American Transplant Congress in 2023. We noticed during the COVID pandemic that belatacept patients had poor vaccine efficacy, had more morbidity and mortality, and we were having a tough time with bringing patients once monthly for the infusions to the clinic. So we developed a protocol to convert patients who were once monthly belatacept to every other month belatacept based upon set criteria. And we chose patients who had an increased risk of infection based upon the criteria here, meaning they had infections already before, which you can see in the bottom table here. And what we did was that we developed some biomarkers around this protocol to ensure that these patients did not have concerns for rejection of graft dysfunction by using markers of rejection as well as immune cell function. So in that protocol, we found that of the initial 18 patients, none of them rejected. Now with 30 patients, we have one subclinical rejection. So the intent here is now to move this now to patients who we described as having only infections to even to patients who do not have a history of infection to try to prevent infection in the future. Can we use TTV amongst other tests to identify candidates for conversion to 2-monthly belatacept? And that's an ongoing project for us at this time. And with that, I'll end. I appreciate your attention. I'll be happy to take questions.
Yeah, thanks, Dr. Gupta. That was really fantastic. Appreciate all the amazing information that you provided. If the audience could send us additional questions in the chat, that would be great. We have several minutes here for Dr. Gupta to answer those questions and maybe expand on a few other topics. I'll start with one question, and I was particularly intrigued by your comments at the end about an individual's trends being more predictive than the population-based values that so many of the papers now show, in typical graphs. But do you have a sense of what would be a significant change in terms of the log fold difference in a patient, and then also how you would look at the time frame?
Yeah, thank you, Steve, for the question. So, I think the one problem with interpretation of the studies out there is because many of them were done with different assays, so it does become different to go from problematic to go from one side to another. There is a publication in just in the last 10 days which tries to derive standardized cutoffs primarily based upon the R gene assay. And that seems to suggest that it may be possible to at least come up with some rough ideas, which you can see here. So this is in the last 10 days. And the idea seems to be that at least from using this particular assay, if the TTV viral threshold is below 4.6 log 10, then the patient may be at a higher risk of rejection. And if the patient is above 6.6 log 10, then they may be at a higher risk of infection. So they, at least based upon this new publication, which tries to put together varied data from a number of sources, in the context of the R gene assay, there does seem to be some suggestion that there may be some population-based thresholds. Having said that, like I said, the publication, the presentation we had from our own data does suggest there is a significant amount of variability. But what we can take away from that abstract also is that even within individual patients, there is a clear trend of this crescendo effect after transplant for the first 3 months, which then kind of plateaus out subsequently by 6 to 12 months post-transplant. So in the context of what we are doing, for example, for belatacept every other month, the thought process here is for patients who have a TTV viral threshold of above 6.6, clearly they should be targeted even in the absence of current infections as candidates for less immunosuppression overall. So that's the thought process we have. And then the intent would be to follow them after conversion and allow them to stay in this area here between 4.6 to 6.6 and the intent being, does it allow us to prevent infections and keep the patient rejection free at the same time?
Yeah, excellent. Thanks. That's very helpful. Yeah, next question. So you showed a nice set of data with belatacept having looked like a stronger immunosuppressive effect versus CNIs. I'm wondering, is there evidence for the other classes of immunosuppressants that are used, the MMF, mycophenolate, or the prednisone, the steroids?
So we don't have data on steroids, at least to my knowledge at this time. I did not come across a publication which looked at steroid-free protocols versus steroid protocols for TTV specifically. For mycophenolate, what we have so far is this one study which I showed, in which patients who were temporarily taken off mycophenolate to allow for a more robust vaccine response to the SARS-CoV-2 vaccine, there clearly was an effect where patients who were vaccinated, their TTV median thresholds went up from a median of around 3 log 10 to around 4 log 10 over a very temporary reduction in immunosuppression. So from 3 logs to 4 logs within 4 to 5 weeks. And then when they reintroduced mycophenolate, it went down again to 3 logs, suggesting that this seems to be a biomarker which responds quickly in terms of the changes we make to immunosuppression, which again, clinically speaking makes sense, because when we cut back immunosuppression for BK, for CMV, we start seeing changes in the patient, but this may be a leading biomarker. So for example, for PK, it does take longer than a month typically for us to start seeing a response in the viral logs going down, but here this is faster. This is within 4 to 5 weeks in this study. So it may be that you can combine this with traditional tests to determine that as you cut back immunosuppression, are you overshooting or not? But once again, those are studies that we need to do to understand this. But this is a promising study in my view.
Yeah, excellent. Okay. Yeah, I think the prospective studies that you mentioned there at the end will address this, since they have standardized changes in frequency of testing. And what about the impact of the other common antivirals that many of these patients are on for CMV prophylaxis, for example, the acyclovir, or CMV treatment, say with maribavir? Do we see any impact of those on TTV, or since it's a completely different viral family and probably different biology, we don't expect to see that?
Yeah, so I think what we can point towards for that question is the initial study from Cell 2013 from the NIH researchers, where they did not find a significant impact of antiviral prophylaxis for CMV on TTV replication. So it's unlikely that there is a significant effect of drugs against herpes viruses which affect viral replication.
Excellent. Okay. Yeah, here's another question. So most of the studies have looked at TTV really in that first year post-transplant, the observational studies, and it shows a gradual decline. What do we know what to expect in the subsequent years, say year 2, 3, even longer than that?
So based upon my knowledge, I think we have data up till 2 years from what I can tell. And typically, most patients seem to settle out in the 3 log 10, 4 log 10 range over time. I think there is more data from lung transplants where it seems to settle down in the 3 log 10 range for sure. But that's what we have so far. I'm not aware of studies that go beyond 2 years so far. But again, one would be surprised if you extended the 2 years to 5 years, would there be a big difference? I would be surprised if that was the case, although I don't know yet.
Yeah. Okay. Interesting. Well, we'll certainly look forward to getting some data and following up with that type of information. Another question we have is how do you place this biomarker in with the others? So the clinical value, the economic value to the patients relative to several of the others that you mentioned throughout your talk.
Yeah, I think the easy answer is we don't know, right? So because we haven't done any studies which combine any of the available biomarkers and try to stand them up head to head, unfortunately. So, and that's a major gap in our literature. Can be used by combinations of biomarkers, except for, I guess, the blood gene expression and the donor-derived cell-free DNA combination, which has some data behind it. But in terms of TTV and combining that with other tests, we don't have that information. To me, this is more of a cumulative immunosuppression biomarker as opposed to a rejection or injury biomarker. I think the value here is, as to take an example of what we just discussed, as we cut back immunosuppression for a patient with an active infection like BK, are we trying to do a judicious job in terms of cutting back? Would be one example of how you could use it currently till other studies become available. Or to identify a patient who you may suspect in the clinical arena is probably over-immunosuppressed, but do you actually have data to support that? And if you had this test in your hands, and the levels were in the billions of copies for somebody who's stable and somebody who's several months post-transplant, that should give the clinician pause and say, okay, well, this does provide evidence to what my clinical sense was, that this patient is over-immunosuppressed, and maybe it is reasonable to reduce immunosuppression judiciously. I think that's kind of where we are right now, and we can't make any bolder statements beyond that.
Yeah. Okay. Yeah. Very, very, very helpful. And in that scenario, do you see value in perhaps baselining a patient, say before you have those clinical suspicions, given the huge variability that we do see for individuals?
So, the peaks of the TTV in all of the published studies are at 3 months, and then the same settle down at 6 months. So if one were to say, okay, I do want to establish a baseline, then 6 months post-transplant seems to be a fair time to do that. But once again, till we get better data on this, it would be harder to try to understand what to do with that information. One problem, of course, is if you get the information available, and then I worry about people wanting to act on that information.
Yeah.
So as an observational data point, it's useful. But is it actually actionable or not? Right now, we don't have the information necessary to make that.
Okay, excellent. Yeah, so a situation where we have quite a bit of information, but still need to gather more information for some refined clinical use and interpretation. That is all the questions I have. If the audience has any more questions, we'll ask one more time. Give it a second here. Yeah, I'm not seeing anything pop up, so I think we'll call it good. We're 5 minutes to the top of the hour. Really appreciate all the information, Dr. Gupta, and enjoyed learning more about tortinovirus today. Thank you.
Thank you.